Welcome back, students, to part 145 of our masterclass. This is the Executive Capstone, where highly technical clinical coding translates directly into enterprise-wide financial strategy. I am so excited for this explainer because today we're bridging that crucial gap between ground-level clinical coding and top-tier executive strategy. We're going to dive deep into health system CMI optimization, risk adjustment, and how absolutely all of this ties into value-based care. But real quick before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel. And share it with friends for this free course on Decode Healthcare with Harshal. Your support is what helps us keep bringing you this advanced curriculum. Okay, let's map out our agenda for today. We'll start with a quick intro and recap, then move into CMI and value-based care. After that, we'll hit inpatient risk, specifically SOI and ROM, followed by CDI governance and compliance, and we'll wrap it all up with a summary and next steps. Let's get right to it. Kicking things off with Section 1, Intro and Recap. We're setting the stage by connecting our last lesson's focus on denial management straight to today's executive perspective. So as we established in our last explainer, the Inpatient Prospective Payment System, or IPPS, reimburses hospitals based on diagnosis-related groups, not individual services. This means that accurate coding isn't just a back-office task. It is the core driver that impacts your reimbursement, your compliance, and your quality scores. Think about where this IPDRG phase sits in the workflow, right between the patient's discharge and the actual billing. Every single diagnostic test, every procedure, and every physician note documented in the EHR culminates right there. If that documentation is vague or incomplete, the resulting DRG is going to be inaccurate, and that leads directly to either revenue leakage or massive compliance risks. Moving right along to Section 2, CMI and value-based care. Let's see how individual coding decisions aggregate into a health system's central baseline metric. The absolute crucial point here is that your case mix index, or CMI, is literally the ultimate indicator of your hospital's financial health. It directly drives financial planning and base reimbursement rates. Now, technically speaking, CMI is just the average of all DRG relative weights assigned to your hospital's discharges over a specific period. But strategically, it represents the true clinical acuity and the resource intensity of your patient population. Furthermore, in today's healthcare landscape, acute care MSDRG assignments don't just live in a fee-for-service vacuum, not at all. They interface heavily with risk-adjusted population health models and value-based purchasing, which includes bundled payments for care improvement and episode payment models. In those structures, your target price benchmarks and your total cost of care are heavily based on your historical MSDRGs. Let's look at the financial reality on a micro level. Imagine a patient admitted for simple pneumonia. If the coder captures a secondary diagnosis of COPD because of clear physician documentation, the case groups to MSDRG 193, that's simple pneumonia with a complication or comorbidity, which carries an expected reimbursement of around $8,500. But what if that COPD is missed because of poor or vague documentation? The DRG downgrades to 195, meaning without a CC, and the payment suddenly drops to $6,200. That is a direct $2,300 revenue loss on a single routine admission. When you multiply that kind of loss across an entire health system over the course of a year, you can easily see how CMI drift occurs and exactly why clinical documentation is a massive executive priority. All right, Section 3, Inpatient Risk. We're going to explore severity metrics like severity of illness and risk of mortality. What's really fascinating here is how IPDRGs take the traditional MSDRG architecture and just expand on it. While Medicare's MSDRG system categorizes severity largely by whether a CC or MCC is present or absent, the 3M IPDRG system, which is heavily used by Medicaid and commercial payers, adds a much more precise 4-level scale. It assigns a subclass for severity of illness, or SOI, and risk of mortality, or ROM. This scale ranges from 1, which is minor, all the way up to 4, which is extreme. Capturing complete secondary diagnoses drives both of these systems simultaneously, ensuring your hospital is actually graded accurately on public reporting and quality metrics. So how do we optimize these risk scores? Well, we have to meticulously capture high-impact comorbidities during acute stays. Vague documentation is our absolute worst enemy here. If a physician just writes CHF, it defaults to a lower weight. But if they document acute on chronic systolic CHF, well, that is a powerful driver. The same rule applies for capturing sepsis with septic shock rather than just writing sepsis, or specifying things like diabetic ketoacidosis, severe malnutrition, morbid obesity, or chronic kidney disease stage 5. And honestly, this goes way beyond just inpatient DRGs. Capturing these chronic comorbidities during the acute stay accurately reflects the patient's true complexity for Medicare Advantage HCCs. That's hierarchical condition categories, and it directly impacts risk adjustment factor or RAF scores for ACO shared savings programs. But hey, remember this, the timing of these conditions is absolutely everything. The present on admission, or POA indicator, is your vital sign here. If a patient is admitted with sepsis and then 2 days later develops an acute deep vein thrombosis, which is an MCC, the POA indicator for that DVT will be N, meaning it was not present on admission. Because of this, it's considered a hospital-acquired condition. It literally cannot be used to increase the DRG payment, and your facility might even face a quality penalty. Which brings us to Section 4, CDI governance and compliance. This is all about keeping that acuity optimization strictly compliant. Lesson: an enterprise-wide value-based CDI strategy is your frontline defense. This sequence outlines a perfectly compliant CDI workflow. It all starts concurrently, meaning while the patient is still admitted, with a CDI specialist actively reviewing the chart. They're looking way beyond just CC and MCC capture to include HCC risk drivers, patient safety indicators, and post-acute care transitions. If they spot a documentation gap, let's say lab values clearly indicate an acute kidney injury but there's no explicit diagnosis from the physician, they generate a query. The clinician then responds in the EHR and the coding gets updated. Now, at an executive level, you must be tracking these interventions. You should be benchmarking your service line-specific CMI against peers and constantly monitoring your length of stay efficiency against the geometric mean length of stay to spot any unusual fluctuations early on. Now, crucially, when we actually generate those queries, they must be non-leading. I cannot stress this enough. This is a massive compliance safeguard. You absolutely cannot suggest a specific diagnosis, like septic shock, just because you want to chase a higher-paying MCC. A leading query would sound something like, based on the low blood pressure, do you agree the patient has septic shock? That is a huge red flag. Instead, a compliant non-leading query just presents the clinical indicators, like the low blood pressure and the high lactate, and asks the physician to provide their definitive diagnosis based on those facts alone. This is what prevents aggressive documentation practices that end up triggering Office of Inspector General, or OIG, fraud scrutiny. Let's take a look at the two extremes here. We've got upcoding on one side and undercoding on the other. Upcoding is intentionally assigning a higher weighted DRG than the medical record legally supports. Make no mistake, this is fraud under the False Claims Act and brings incredibly severe penalties from the OIG. On the flip side, undercoding happens when you fail to capture a valid CC or MCC just because of vague documentation. This results in straight-up revenue leakage and an artificial drop in your CMI, which falsely makes your hospital look a lot less complex than it actually is. The true goal of your CDI program is ethical optimization, finding that sweet spot right in the middle. You want to ensure your hospital is paid fairly and completely for the actual severity of care provided, supported entirely by undeniable clinical truth. So as healthcare executives and RCM leaders, you have to constantly ask yourselves this exact question. Are your CDI queries ethically optimizing your revenue, or are they leading physicians and practically inviting an audit? Establishing strong clinical validity thresholds for high-impact diagnoses, things like chronic respiratory failure or severe malnutrition, and implementing routine internal compliance audits is exactly how you maintain revenue integrity without ever crossing the line into compliance risks. Finally, we arrive at Section 5, Summary and Next Steps. Let's review our executive takeaways. To wrap things up, today we've learned that mastering your case mix index, really understanding severity metrics like HCCs and RAF scores, and enforcing strict CDI governance, these are just non-negotiable for a health system's financial viability. Your CMI isn't just a number on a spreadsheet. It's the absolute financial reflection of your clinical reality. Accurate risk adjustment mechanisms dictate exactly how you fare in both fee-for-service and value-based bundled payments. And a compliant, robust CDI program, that is the engine that drives this ethical optimization while protecting your institution from catastrophic audits. Next time, in Part 146, we're going to tackle the regulatory side head-on with the OIG work plan, corporate integrity agreements, and fraud defense. But before we go, I want to leave you with a provocative thought. Is your health system's documentation reflecting the true cost of your care, or are you leaving your clinical truth unwritten? Think about that. If you were enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in the next masterclass.